So good evening all. Welcome everyone to the IRA Kerala PG case presentation series in association with Janomed. Towards this, I welcome Dr. Gomadi Subramaniam, President Kerala IRA, Dr. Ijo Matthew, Secretary Kerala IRA, and Dr. Ramesh Shanai, Program Coordinator. And the topic of today is breast imaging, PG case presentation. And this is being moderated by Dr. Rajesh Kannan, Professor, Amrita Institute of Medical Science, Kochi. I welcome Dr. Rajesh Kannan. And our faculty is Dr. Janagi Thamarajan, Clinical Associate Professor, Department of Radiology, Amrita Institute of Medical Science, Kochi. Hearty welcome, Dr. Janagi. And now over to Dr. Rajesh Kannan for the introduction of the speaker.
Yeah, thank you, sir. Thank you. I sincerely thank IRIA Kerala chapter for giving us this opportunity. And today going to be three interesting PG case presentation from Amrita Institute of Medical Science. Will be coordinated by Dr. Janagi P. Tharmarajan. She is the associate professor at Amrita Institute of Medical Science, Kochi. She did her fellowship in breast imaging from Toronto, and last say 7-8 years she has established a separate breast clinic. She's not just a radiologist, she is also a clinician, and she is involved not just the diagnostic imaging, involved in biopsy and the counseling, all aspects of the breast imaging and its management. So today we are going to see three interesting cases which will be coordinated by Dr. Janagi. Yes, Dr. Janagi, you can carry on. Maybe you can give a small intro regarding what you are planning, then we can start with the PG.
Yeah, thanks for the warm introduction, and thanks a lot IRA Kerala chapter for giving us an opportunity. So like Dr. Rajesh Kannan has told, nowadays we have started calling ourselves as clinical breast radiologists. So because we are equally involved in the patient care as well as counseling, and along with the diagnostics as well as the intervention. So what we usually see, because most of the cases they come to us for reference. So it's today the routine cases everyone knows, but today we have just picked up three cases just to highlight regarding how to approach each case. The first case by Dr. Mridula will be basically on lobular cancers. So lobular cancers are something that the patient will feel, but they may be mammographically according. It's quite challenging. So she will be taking us through the challenges of an invasive lobular cancer. It's a peculiar case. And the second case is by Dr. Ritesh Reddy. So he will be taking us through a complex cystic mass, how to approach it. And the third case is by Dr. Bribin. So he'll be taking us through a case wherein what the calcifications and how to approach it. So without wasting much time, over to you, Mridula.
This is a case of a 39-year-old female presented with a right breast lump of 4-month duration. So we are proceeding ahead with the mammography because we are concerned about the other breast also. This is a 2D mammography image of both breasts showing scattered fibroglandular densities bilaterally. In right breast, there is an extensive architectural distortion in the central and lateral quadrant with no associated suspicious calcifications. There is nipple retraction and perioral skin thickening. And there was no obvious mass seen. So tomo was done, which showed a mass with irregular margins and with extensive speculations.
So can I ask the questions now, or?
Yes, ma'am.
Yeah. So what exactly is this second image, that tomosynthesis? Can you say something about it?
Tomosynthesis, it is like you see like a thin sections, like we are able to make out a underlying mass which was not seen in a 2D image.
Okay, so the margins of the mass become more clear.
More clear.
Okay. Next, continue, please.
Left breast also shows extensive architectural distortion without any associated suspicious calcifications in the upper and outer quadrant. In this also, in a 2D image, we are not able to make out margins of the masses clearly. In TOMO also we see architectural distortion with masses in the upper and 2 masses in the upper and outer quadrant. This was followed by a targeted breast ultrasound in which the right breast at 6 o'clock position 4FN showed a hypoechoic mass with the irregular margin, and posterior margin was not seen due to extensive acoustic shadowing, and it was not showing much vascularity.
Can you say what is this 4FN?
4 centimeter from nipple.
Okay, so how do you measure it approximately?
We measure with the probe. The probe we use here is like some 6 centimeters. So from nipple we can measure the distance to the mass with the probe. How much length we are covering with the probe.
And why is it important to measure the distance from the nipple?
To give the exact location of the tumor.
Okay, so basically what we are doing is we are giving a correct address to the tumor.
Address to the
that
tumor.
Even if the patient is going to some other place also, or if the patient is coming for follow-up, what will happen? 6 o'clock may be a large area. So we should know exactly what is the distance from the nipple. That is very, very important. So we don't have to measure the exact distance. So what we can do is roughly, we know the distance, we know the length of the probe. So usually the small parts probe is about 5 or 6, mostly 6 centimeters or 5 centimeters. So that way, one probe length, it's about approximately 6 centimeters. Half of it we can call it as 3. So approximately we have to measure and then say how means what is the distance from the nipple. That is very, very important, and the distance has to be from the nipple, not from the areola. Okay, you can continue.
Left breast showed 3 hypoechoic masses with irregular margin. One at 6 o'clock position at distance of 5 centimeter from nipple. The other 2 were at 11 o'clock position at a distance of 3 centimeter from nipple, and 4 o'clock position at distance of 5 centimeter from nipple. Axillary right axilla showed 2 hypoechoic lymph nodes with the cortical thickness of 4 mm in the level 1. Left side also, level 1, there was hypoechoic lymph node with focal cortical thickness of 5 mm. So this was
so based on the mammography and ultrasound findings, you have to give your assessment. Yeah, that is the conclusion. So that is a
so this masses were having suspicious features in the form of architectural distortion, and ultrasound also showing hypoechoic with irregular margin. So it's highly suspicious for malignancy. So we give BIRATS 5 for both the breast masses.
Okay. And what will you be recommending?
I'll be recommending an MRI before a tissue biopsy because we do to know the exact number of lesions in the left breast and the possibility of a breast conservation.
Yeah. So ideally, before asking for an MRI, means you have to give the BIRATS. So for example, if you are doing, you're giving it as BIRATS 5. Yes. The MRI does not show any enhancement. What will you do? You're doing, not for this case, in general, you're giving a BIRATS 5 based on mammography as well as ultrasound. So you're doing a problem solving MRI, but MRI does not show anything. So what will you do? Will you just follow? You already given BIRATS 5.
No, we'll proceed with the biopsy from that suspicious lesion.
Yeah. So this is what has to be highlighted, because it does not depend mean that MRI is the ultimate. So in whichever modality the mass is most suspicious, we have to do biopsy under guidance of that. Either it can be mammography or ultrasound or MRI. So before we proceed with MRI, already our BIRATS should be ready, and it should not be that once you decided on biopsy, so MRI will help us to target the lesion. It can just optimize the lesion. It will help us to target the lesions and also to enumerate, to know the quantity, the extent, and how to plan for surgery. For these things, MRI will be useful. But based on MRI per se, if in case if it's a BIRATS 3 lesion, So we are planning a short-term follow-up, but still, if you're asking for MRI, if MRI is showing something suspicious, then we go ahead with the biopsy. So MRI should not be used to guide our treatment. So even before we go in for MRI, we should know what we are planning to do. Okay, so in this case, ideally, we could have gone ahead with the biopsy initially itself. Right breast, there was no problem, but left breast, it was non-palpable. So all the masses were screen detected. They were not palpable, so we're not sure how many lesions were there. And Mridula, you had shown these lesions in multiple quadrants. So what were you suspecting clinically?
Because it is in bilateral breast and multiple lesions are there. I think of a lobular carcinoma, because lobular carcinoma most common present bilateral and multiple masses.
Yeah. So right breast, so we know where the lesion is. So left breast, we are seeing in multiple quadrants. So if it is, yeah. So now proceed.
Then we proceed with an MRI. This is a T1 sequence showing scattered fibrogranular tissue density bilaterally, and we see an extensive architectural distortion in the right breast with the nipple retraction, and left breast in the central quadrant, and the left breast also shows architectural distortion in the upper quadrant, predominantly in the upper quadrant.
Then what else do you see on T1 sequences?
T1 sequences, we can see the fat containing lesions like lipoma, and we can look for a lymph node.
Yeah. So mainly it is used to know the breast composition as well as to look out for the lymph nodes.
Lymph node. So T2 stir image show in the right breast shows mass with irregular margin in the lower central quadrant. In left breast, we see two masses, one in the upper outer quadrant and in the lower outer quadrant, in the background of architectural distortion. This masses could be better appreciated in a MIP image, where we see the right breast mass, a single mass, and the left breast multiple masses.
Okay.
Post contrast images, we see an intense rapid enhancement in these lesions. So MRI wise also, these we see this is suspicious, highly suspicious for malignancy, and right breast locally advanced lesion, and left breast multicentric masses, we give BIRATS 5.
Okay. When do you see it is locally advanced? What is the criteria for that?
When the masses associated with the nipple retraction and skin changes, and we also have positive lymph nodes with no distant mets.
Yeah. So basically, locally advanced is something wherein it's all T4 lesions.
T4 lesions.
T4 lesions are locally advanced. Okay. So T4 means either it is
T4
chest wall involvement,
or
skin involvement,
or it can be inflammatory breast cancer.
Inflammatory breast cancer. So just because focal skin tethering, it may, even though the lesion size may be smaller, we cannot actually, we'll call it as local, but it cannot be included in T4. The focal skin tethering can occur sometimes, even if it's small size lesions. But here we are seeing there is significant, the breast is distorted, the skin is thickened, so definitely there is skin involvement. So that is why on the right side, this classifies as a locally advanced breast cancer. And on left, it is multicentric. So when you know it is multicentric, so what is the main thing? Can you conserve the breast? It's important that you tell the surgeon. So,
when it is multicentric, the possibility of conservation is less.
Okay, and another terminology, if you're seeing two lesions, they're close together, so it will be called as multifocal. So,
multifocal. If it is multifocal in one quadrant, then there is possibility for conservation.
So it is very, very important. It's an important part of the radiologist to inform the surgeon regarding the number of lesions, the location of lesions across different quadrants, so that they can plan the surgery accordingly. And all these have to be done pre-operatively, and especially the cases where the lesions are non-palpable. Okay, so now we'll proceed with the what's the next step now?
Ultrasound guided core biopsy was done from the right breast as well as the left breast mass, and which was consistent with the invasive lobular carcinoma. And FNAC was reactive lymph nodes, both right and left axillary level 1 nodes. And IHC turned out to be estrogen progesterone receptor positive, and HER2 it was 2+. Ki was 40 to 45%, which is a luminal B type.
Okay, so what do you understand by the immunohistochemistry for the breast tumors? What are the main types?
Types are luminal A, luminal B, HER2 positive and triple negative. Luminal A will have ERPR positive, HER negative, and Ka will be less than 14%. Luminal B was ERPR and HER2 positive, and Ka is more than 14. Triple negative, all three are negative. In HER enriched, HER2 will be positive.
Okay, so it's and all this information can be obtained with the core biopsy on a proper core biopsy.
Proper core biopsy and from immunohistochemistry from that biopsy.
Okay, and for core biopsy, which needle is used routinely for breast?
14 gauge.
14. Okay. So now proceed.
And
now,
because HER2 was the 2+, fish was advised, and which was negative. So she was
labeled as luminal B. Okay.
Luminal B.
So next, would you like? How do you proceed now?
Now, because it is now we see like a locally advanced one breast and multiple multicentric mass in the other breast, we have to do staging for this patient. So we go ahead with the PET-CT.
Okay.
PET-CT, both the right and left breast masses were FTG avid, and the axillary nodes were not avid. Apart from that, there were multiple sclerotic bone lesions in the axillary appendicular skeleton. And other than that, there was no FTG avid distant mets in liver or other organs. And for bone, scintigraphy was done, and there was diffuse increased uptake in all the multiple bones in axillary and appendicular skeleton, and spectroscopy also showed increased tracer uptake in these bones.
Okay, so now you got a bilateral mass.
Bilateral mass with bone only mets. And
okay.
Now treatment wise, the role of surgery is not definitive because it's bilateral. So it was proceeded with the chemo, planned for a chemo and RT. And first patient was given 8 cycles of chemotherapy. Then follow-up PET-CT was done.
Okay, so basically what happens is, in case of metastatic setup, surgery does not have a role except in one condition, wherein even if the patient is metastatic, we can go ahead with the surgery. You must have seen nice, big, large, fungating masses. The locally advanced breast cancers. No. Even the invasive cancers, what happens is, when the masses are bleeding, so you don't know what to do. So toilet mastectomy can be done for local control, even if the patient is metastatic. That is for local. Either toilet mastectomy or give RT to the breast for local control. So otherwise, once it is metastatic, all these cases have to be discussed in the tumor board. So the decision will be taken regarding the optimum treatment for the patient. Okay, so this lady was given chemotherapy and
PET-CT was done for a response assessment, and the bilateral breast lesions were not showing FDG avid this time, and bone lesions also, compared to the prior, the sclerotic bone lesions were seen, but it was not FDG avid. So, so there was a better response to the chemotherapy. So after this, follow-up breast ultrasound was done, interval breast ultrasound was done, and there was a complete response to chemo. So after complete response to chemotherapy, a patient was planned for bilateral breast RT. And she was on hormonal therapy and bisphosphonates also.
Yeah, so actually, in this case, the patient was given an option whether she wants bilateral mastectomy or bilateral breast RT in view of metastatic setting, and since she had a very good response, so she opted for bilateral breast RT.
Breast RT. This is a follow-up mammography. We see a normal left breast with scattered fibrogranular tissue, and there are no suspicious lesions seen now. Even in tomo, we were not seeing any suspicious lesions or any calcifications. In right breast, we see a subtle architectural distortion in the lower quadrant, but that may be a scar tissue or a residual lesion. So this was followed up by an MRI to look for the residual lesions. MRI is a T1 image. We see a focal skin thickening in the right breast, and we see the fibrogranular tissue and subtle architectural distortion. And this is a MIP image. When compared to the previous MRI, there is almost complete resolution of the bilateral breast masses, and lymph nodes are also appearing normal. This is a post-contrast image where we see only the background parenchymal enhancement, and there are no enhancing lesions. So there was a good response to chemo and RT. And patient was kept on follow-up. This is a recent mammography image which shows no architectural distortion or suspicious masses or calcifications.
So now what BIRATs will you be giving?
This will be BIRATs 2 because we see is post
Post-therapy changes is there.
Post-therapy changes are there, and she has to be stable for, we have to see stability for 2 years.
No, but yeah. No, that is for the BIRATs 2. Okay. So she's stable and post-therapy changes are so okay, good. So would you like to sum up?
So basically with the invasive lobular carcinoma, it is most commonly seen as multiple lesions and in both bilateral breast, and patient will present as a palpable with a palpable concern in either of the breasts. Because this pathologically, if we see this lesion fails to elicit a desmoplastic reaction, so we may not sometimes pick up lesions in a mammography, but even with the negative mammography with the patient which has a palpable concern, we should go ahead with an ultrasound or MRI to look for lesions.
Okay, so basically, if you want to do a confirmatory test for invasive lobular carcinoma, so what is it? A pathological marker?
ECAD.
ECAD, because in invasive lobular carcinoma, the cohesive effect, cohesive property of the cells are lost of the tumor cells. So that is why they just spread along a single line. So they won't form a mass. They're not mass forming, but they must have heard about this India file appearance, Indian ink appearance. So that is how they appear on under microscope also. So for confirmation, ECAD test is confirms the presence of invasive lobular carcinoma. Then about 19 to 43% of the cases, they are missed on mammography. They may be palpable, but missed on mammography. So invasive lobular is very, very notorious. We have to keep in mind that whenever a patient comes with a palpable lesion, but it is negative on mammography, always go ahead, do an ultrasound and confirm. And if you feel something like it is an invasive lobular carcinoma, scan the same side as well as the opposite side. because they're very, very notorious for being multicentric, bilateral, and so all the lesions have to be detailed before the start of treatment so as to enable a better patient care. Okay, thanks.
Thank you.
We'll go to the next one.
Yes. Good evening, everyone. Here we are seeing a 66-year-old lady who has come for the routine screening mammography. On bilateral breast mammography, we were seeing like scattered fibrogranular tissues on either side. And then in the right breast, we are seeing like a oval equal density mass with circumscribed margins, but without any associated suspicious calcifications. But on the other side, left side, we are seeing like a cluster of amorphous calcifications, but not associated with any masses on tomosynthesis. Like if we, these are the like cluster of the amorphous calcifications on the CC and MLO. And when we subjected to the like targeted ultrasound, in the right breast one, it was corresponding to the oval mixed echogenic mass with indistinct margins. On the left side, only we could see like a simple cyst with calcifications within. And depending on this calcifications, once if we review these calcifications, usually we'll approach it with usually by morphology and the distribution pattern and its change over time. And these calcifications, usually they will form either like in the terminal ducts that we'll call like intraductal calcifications, or within the acini, which are the lobular calcifications. The intraductal ones, these are like the calcified, the cellular debris or secretions in the ductal lumen gets calcified, and they form this ductal pattern, the fine linear or branching form of distribution. And these are like the suspicious ones. And these can be extremely variable in size, density, and form. Whereas the lobular calcifications, usually they fill the acini and they will be more so homogeneous, and they'll be usually like diffuse and bilateral, and they are almost always benign. And with the morphology, usually the benign morphology will be like a skin calcifications, vascular, popcorn, fat necrosis, milk of calcium, suture, and dystrophic ones. And the suspicious ones are the amorphous, coarse heterogeneous, fine pleomorphic, fine linear or linear branching. If you see these are like usually only if you see only with the oblique and CC images, we may mistaken them as the within the parenchyma or some calcifications. But only if they are like dermal based, like on the skin, they will show same configuration in both the CC and MLO views. So to confirm it, we can take a like tangential view to the skin, which will confirm it the skin calcification, which are like the benign. And then these are the if they are like linear parallel tracks, they can be they are the vascular calcifications. Sometimes when the calcification is only on the one side of the wall, they can simulate like the intraductal calcification. So when we are seeing the vessel along with it, so then we can say it as the vascular calcification. And then the popcorn-like or coarse calcifications in involuting fibroadenomas. And the other one is large rod-like calcifications but these are will be like suspicious if they are like very fine linear and these large like they are usually like bilateral, but the suspicious ones are the fine linear ones, which usually we'll be seeing more so like in the segmental or in the like on the one side.
These rod-like calcifications are most commonly seen in which condition?
Like plasma cell mastitis.
Yeah. Okay. Continue.
Yes, ma'am. And the next ones are the round calcifications. Like these mainly depending on the distribution pattern. Like when they're scattered, we'll give like BIRATs 2. And if they are like isolated in clusters, or if they are newly appearing, we'll give the BIRATs 3 or 4. And in the BIRATs recent classification and the previously ones, the punctate ones, which are less than 0.5 mm ones, are also included in this round calcifications. And the other one is the rim calcifications, which are typically seen in oil cysts and fat necrosis.
And just these round calcifications, once you're seeing, so how will you proceed further? Any specific things you'll do to make sure the round calcifications are benign?
Like if they are like seen previously, like in the previous imaging now.
Okay, so these round calcifications are usually associated with fibrocystic change. So what
Yes,
happens is, what about a tangential, means you take a 90-degree view for that? So cup and saucer appearance, that is very, very classical of round calcification. So what happens is, when you do a CC view, so since the calcifications are within the cyst, they will appear round. Whereas in a tangent, means then you make the change the degree to 90 degrees. You compress the breast for almost 5 minutes, and when you are taking, they will be the form of a saucer. So whenever you see this cup and saucer kind of appearance on mammography, they are pathognomonic of benign breast disease. So you don't have, then once you're seeing this change in shape, so you can very confidently label them as BIRATs 2, even on screening mammography. Okay? Yeah.
Okay. And next ones are the amorphous ones. We'll call it as amorphous if they are like indistinct and hazy. Like they'll be having no clear defined shape and form. And of them, like the 20% are malignant, which can be like DCIS and IDC. And mainly here also like distribution pattern is very important. When they are like unilateral clustered or a new one follow, they will be labeled as BIRATs 4. And the other one is coarse heterogeneous calcifications seen in like fibroadenoma, fibrosis, post-trauma, and the DCIS. Same with the, if they are multiple and bilateral, they favor benignity. Or if the clustered, linear, and segmental, again DCIS is considered. And these are the fine pleomorphic or fine linear branching pattern. They usually form the pattern of ductal pattern. They'll be like in the cone shaped, usually like towards the nipple. And when we come to the distribution pattern, this is like the diffuse, in the regional one, the clustered and segmental ones. In this, like the clustered, linear, and segmental ones are suspicious ones. So in our case, these were the amorphous calcifications, which are not typically benign. And so we have kept like a short-term follow-up, but the patient didn't turn up for the timely follow-up. But at last, a patient after 4 years, she turned up with a palpable concern in the left breast. At the time, like when we saw mammography was done, and then we saw the right breast mass was stable, but on the left side, on the left breast, we could see a cluster of pleomorphic calcifications. But on even on the tomosynthesis, we could not appreciate any defined mass. And when we subjected to the targeted ultrasound, these were the cluster of pleomorphic calcifications. And this in comparison in 2018, in 22, they are like increased in number, and it is like a cluster of pleomorphic calcifications. And on targeted ultrasound, on the right breast one, it was the right breast mass was stable in size, and this could represent a fibroadenolipoma. Whereas like on the left breast, at the area of palpable concern, like there was like non-mass lesion with intralesional calcifications and posing a posterior acoustic shadowing. And these non-mass lesions are they are like the discrete identifiable. They will be like a area of altered echo texture compared to the surrounding, which does not conform to a mass or shape. Like they won't be having like a defined convex borders, and they can be seen in wide range from benign to malignant. Benign in fibrocystic change and stromal fibrosis. Malignant you can see in high-grade DCIS and breast cancers, ductal and lobular invasive. And favoring malignancy ones are like if they are associated with calcifications, favors malignancy. And if on mammography, if they are correlating to calcifications or any asymmetric density or architectural distortion, they more favor of malignancy. And they also correlates mostly to usually to the non-mass enhancement on MRI.
Yeah, and this non-mass lesion, is it a part of BIRADS?
No, ma'am.
Present
It
BIRADS?
is no, ma'am.
So right now it is not a part of present BIRADS, but already they have indicated that this will be included in the subsequent edition, the next edition, which is coming next year. So that's why very, very imperative that all of us, we should be aware of it. So
And
next
this
step is, yeah.
And this non-mass lesion was subjected to ultrasound-guided core biopsy. And then after the biopsy, we took the specimen mammography, whatever we took for the biopsy, because to not miss the targeted calcifications, whether they are obtained or not.
So for this case, would you prefer doing a mammo-guided biopsy?
Mammo, because we could not see the
You are seeing the calcification. So either what will you prefer, like mammo-guided biopsy or ultrasound-guided biopsy? For this case,
ultrasound-guided biopsy.
Why? You're right. Why? Because first and foremost, if you are able to see it, it is much easier to do and much cheaper also as compared to mammo-guided biopsy. Stereo biopsy is quite expensive, and it may be causes inconvenience to the patient also. And so that is why always an ultrasound-guided biopsy. So if you are seeing a lesion, always prefer doing a biopsy under ultrasound guidance. If not by ultrasound, then do it under mammo guidance. So for us, since the calcifications were the main area of interest, and we could there was no discrete mass. If you are seeing a mass, no doubt. But since it was a non-mass area, we had to be sure that the calcifications are in the specimen. That's why specimen mammography was performed to confirm the calcifications. Okay, proceed. So what do you expect? Yeah.
And then on histopath, it was turned out DCIS. So and then recommended like staging MRI breast, followed by mammography guided bracketing of calcifications, planned for breast conservation surgery. So MRI breast was done, and on T1 weighted sequences, we can see the scattered fibroglandular tissue seen in both the breasts, and we could see the T2 bright area in the retroareolar region.
So what does it indicate? It's T2 bright.
Like edema over there.
Okay. So that is why in some cases we ask for an MRI prior to biopsy. Because especially like in the previous case. So what happens is once you're doing the biopsy, edematous changes will be there. So it becomes difficult for us to find out. For us, this case, particular case, we knew it was calcification, we could localize it. Like in the previous case, it was invasive lobular. So we're not having, there's nothing on mammography by which we could localize. So that is why in certain cases, it's always preferable to do an MRI to characterize the lesion before proceeding with biopsy. Because post-biopsy, hematoma as well as inflammatory changes are expected. Okay. because generally 90% of the lesions that are bright on T2 are considered to be benign. Okay, proceed.
And then on post contrast images, we could see rapid enhancement, which is in segmental distribution, and it was persisting without any, actually in this case, without any segment washout. It was persisting in the delayed. And there was the corresponding lesion was showing the diffusion restriction. And on MIP images, we can see the overall in the sag and axial, the lesion. So in the MRI breast, we could see this clumped pattern of non-mass enhancement in segmental distribution, which was rapid and persistent enhancement. And the overlying skin was normal and the axillary normal axillary lymph nodes. And when we come to this non-mass enhancement, why we are calling it as because it does not meet criteria for mass, and we can see the intervening fat or fibroglandular tissue between the enhancing components, and which favors the invasive malignancy or the segmental and clustered or clumped one. And then the main thing is washout dynamic type and very low ADC values. And kinetic curve assessment, usually the malignant lesions will show rapid initial enhancement and delayed washout. And the benign lesions will be like slow initial enhancement and they will progressively increase. However, like in lesions, overlap can happen. And later on, the patient underwent the left breast wide local excision.
Yeah, so
and
what happens is beforehand, if you are able to localize the lesion, so the patient can be offered the option of either mastectomy or breast conservation. So this particular patient, probably she opted for breast conservation. So now again, it is our job to find out the lesion and show it to the surgeon. So how can you do it? Any specific thing, because there are calcifications. So you can just mark over the skin. So anything else you can help the surgeon?
Localization with the wires.
Okay.
Wire localization, we can, the bracketing of calcifications, so that we can mark the borders.
Okay, because based on MRI, we know the lesion extent. Then we can bracket the calcifications, and also once the specimen is out also, what can we do? We can do a specimen mammography. And make sure the margins are fine before they close the patient. Okay. And what is the final HP?
Final HP was DCS without invasive malignancy, and the axillary nodes are free of tumor. Okay.
So this case highlighted that whatever calcifications, in case they are suspicious, always we have to make an attempt to know the cause of the case. Otherwise, we have to emphasize to the patient that the patient is for a short-term follow-up. But if stereo biopsy procedures are available, it is much easier to go ahead with a biopsy straight away. But we have seen that a lot of cases that during COVID, most of they didn't come out of the house for 2 years. Even though they were having lumps, they did not get out of the house for 2 years. And it is still continuing this year. So we'll be seeing a few more cases of the locally advanced disease because the patients did not get optimal care for the 2 years of COVID. So this is, even though she was having the lump, but she couldn't come. She thought it would be more dangerous for her to come out, so she let the mass grow. Luckily for her, it was not an invasive carcinoma, and we were able to offer best treatment for her. Okay, the next case, please.
Thank you. Thank you.
Thank you.
Good evening, ma'am. Today I'm presenting a case of a complex cyst that turned out to be malignant, and I like to highlight the role of biopsy in that case. Am I audible?
Yeah, please continue.
Okay. This is a case of 49-year-old perimenopausal lady who came for evaluation of a left breast lump of 6-month duration with mild increase in the size. Here is a mammograph image. In the first view, you can see that the left breast, there is no suspicious masses or architectural distortion or calcification. There is a heterogeneously dense breast. And on the right side, there is some in the 9 o'clock position at around 3.2 centimeter from the nipple, there is an equal density mass, which is around 4 to 3 centimeter, which is partially circumscribed in margin, and there is some pleomorphic calcification in around that within that lesion. And in the same quadrant, there is some lobulated mass, which is also around 4 to 3 centimeter, without any suspicious calcification. And this is 3D tomosynthesis image confirming the same in thin section. There is also like left axilla was also showing an enlarged round dense lymph node, which was around 3 centimeter. Ultrasound was done in view of these mass lesions, and which confirmed that 9 o'clock position around 12 centimeter from nipple, there was equal density mass with circumscribed margin, and 10 o'clock position from 5 centimeter from the nipple, there was complex predominantly solid cystic lesion, which is around 4.7 centimeter, and the solid component of that lesion was showing moderate vascularity, and which was measuring around 3 into 2.6 into 3.7 centimeter. There were no posterior features, and left axilla also showed the corresponding to the mammogram. There was one large suspicious lymph node, which was like with effaced hilar and extra hilar cortical blood flow. And cortical thickness was 1.5 centimeter. This is the Doppler image of the lesion and the left axillary node. So we proceeded with core graded biopsy, investigated, and the aspirate turned out to be bloody, and histopathology came out as infiltrated ductal carcinoma grade 3, and the immunohistochemistry panel was sent with triple negative status, and the K67 was 60%.
So do you agree with the pathology report?
Yes, ma'am. It's showing solid mass, which can, and solid mass with cystic component also, and
so we'll call it as concordant malignant.
yes, ma'am.
Okay, so whatever the pathologist says, that's the final.
Yes, ma'am.
So if you are expecting a benign finding, but if they're calling it as malignant, we'll call it as malignant only.
Yes, ma'am. Yes.
But if you are expecting a malignant finding and they are calling it as benign, so that will be discordant benign. So then you have to do additional workup. Okay. So always, if you are agreeing or disagreeing with the pathologist findings, always that has to be mentioned in the report. So this is a recommendation that is to be given in a radiology report once the pathology results are available with further recommendations. So what will you recommend further?
For the recommendation,
no, for her next step.
Actually, we have to work up for the distant. We have to work up for the any metastasis is there or not to confirm it to be locally advanced breast cancer or not. Based on that, we can plan for the further treatment.
Okay. Correct.
So same was done here for the patient, and where PET CT was done, and which showed the uptake in the primary lesion, and the lesion near to that other one didn't show that much uptake, and there was no distant metastasis. So we planned for NSCT for this patient. And there was this was the first follow-up for 4 cycles of neoadjuvant chemotherapy, and which showed significant partial internal regression of the both masses at 9 o'clock and 10 o'clock position, which were around 4 centimeter previously, and now it is around 50%, almost 50% reduction in size. And the left axillary node also improvement in status.
Okay, so what are the 4 types of regression that? What are the 4 types of response assessment on chemo during NACT?
Ultrasound follow-up can be done.
No. Depending upon either the masses can progress. So when do you call there is progression of masses?
While in NACT, if there is progression more than 20% size. Yes.
Okay, and the regression is when there is
50%,
30%.
30%.
Okay, and either they can complete, they will complete regress, they will regress, or they remain stable. When the
Yes,
change is less than 20%, they remain stable. When
Stable.
the size, like you told, 50 more than 50%, that is regression. 20% plus or minus is stable actually.
Okay.
More than 20% increase is progression.
Yes,
And what do you mean by NACT?
Neoadjuvant chemotherapy that is done for usually inoperable masses or with the nodal big nodes or something which needs to be reduced in size before the planning surgery.
Yeah,
And
neoadjuvant chemotherapy, especially we use when it is a localized disease.
locally advanced breast
It should be
cancer.
localized to the breast tissue. But when we feel that while giving chemotherapy, the patient, surgical outcome will improve. Because when you're operating a locally really big lesion, the cosmetic outcome will not be good. And also with such an old disease, we have to downsize it. When the axillary lymph nodes are involved, it means that even the PET does not show anything. There are chances of micrometastasis in the bloodstream. So in order to optimize that, we have to go ahead with the NACT. And radiologist's role is very, very important by showing the, especially if showing the lymph nodes to be malignant, then it is much easier for the staging of the patient.
Yes, yes,
And,
yes, ma'am.
Yeah, and in this patient was having lymph nodes at what levels? One lymph node she was having.
Yes, ma'am. Few lymph nodes were there. The biggest one was like level 1. At more or at level 1, and that one was very big, like from 3 centimeter it was.
Okay, and what all levels will you check on an ultrasound?
Level 1, level 2,
and the supraclavicular region also.
And supraclavicular, yeah.
So if you are finding a lymph node in the supraclavicular region and in the axilla, which one will you put an do FNAC from?
Supraclavicular.
Yeah, why? Because that becomes, the stage becomes
like
N3.
3, ma'am, N3. Yeah.
Okay, yeah, okay, proceed.
Yes, ma'am. Yes, ma'am. As you told, like NACT will help in converting the surgery to breast conservation, and there will be downgrading of the lymph node, and enables micrometric eradication, and evaluation of the sensitivity of the chemo agents also possible with the NACT. So next 4 cycles were continued due to a good response to NACT, and which showed further increase, further response to the chemo. And there was 9 o'clock position, there was mass which appears to be disappeared now, and 10 o'clock position, 5 that lesion also reduced to size of 1.3 centimeter, and left axial lymph node also reduced to 0.3 cortical thickness. So the patient was finally proceeded with breast surgery. I mean, like the wide localization was planned, and it was done, and the histopathology came out to be infiltrated ductal carcinoma. And after 1 year follow-up, this mammo was taken, and there was no suspicious mass in the corresponding region, and it turned out to be stable in 1 year. So from these points, I need to highlight, like whenever you are considering, when you are seeing a solid cystic complex mass, we should not miss. We should not neglect a carcinoma in the corresponding lesion. So we should consider intraductal papillary disease, papillary carcinoma, or mucinous carcinoma, which all will show solid cystic components. And regarding to that, one hematoma can also be considered if there is a history of trauma or a previous surgery, or even anticoagulant therapy history is there. That also can be considered, but I never miss a malignant lesion. So while approaching a cystic mass of the breast, first see if it's simple cyst or not. If not a simple cyst, you always do image gather intervention to exclude a solid mass because of this necrotic component of the tumors. And this is usually what we need to do when a complex cystic mass is seen. The decision to whether an interventional technique should be used is guided by a clear indication. It should be compatible with the patient history and result of the mammography. And the following alternatives we can use, like either close monitoring or sampling. Sampling can be done as FNA aspiration or biopsy. FNA is the first interventional procedure that should be performed when it is difficult to differentiate between complicated and a complex cyst. And the purulent fluid suggests when the aspirate is having purulent fluid, that suggests an inflammatory lesion should be sent for microbiology analysis. However, if a bloody aspirate is obtained, that should raise the possibility of a malignancy and should be analyzed by cytology. And when solid cystic component is there, first the aspirate should be taken, and after the aspirate, still the solid component is persisting. That is an indication for core biopsy, which should be performed in the same session to avoid the delay of the diagnosis of the tumor. And biopsy is the second consideration, which should be the first intervention if there is a proven solid component associated with suspicious finding in the mammo, like microcalcification, architectural distortion, etc.
Okay, so here what care would you take while biopsying a complex solid cystic mass? Sometimes the cystic component will be predominantly cystic
yes,
component. So if you are doing the biopsy, what can
yes,
happen?
Cystic component can regress.
And if it turns out to be malignant, what do you do? Report is coming as malignant. So
yeah, ma'am. Like we can.
Ideally, we have to place a clip.
Ma'am. Yeah.
Okay. So as to identify for large lesions, it's fine. But whenever it's a small lesion, complex solid cystic lesion, ideally we have to place a clip to mark the site of biopsy. If it is benign, we don't have to do anything. We just have to do a follow-up. But if it is malignant, so we can always localize the clip under mammography guidance.
Yes, ma'am.
Okay, so that has to be. Okay, thanks for the presentation. That's good.
Thank you.
Okay, so through 3 different cases, we just went through, highlighted how the different, if it is invasive lobular neoplasm, how to approach it. And in case of calcifications, what should be the correct approach, especially with regards to the morphology as well as the distribution, which is equally important. And in case of complex solid cystic mass, how should the approach be? Okay, thanks for good presentations. I'm proud of my PGs.
Thank you, Dr. Janagi. There is a one query in the chat box. I think it is for the second case. Left breast mammo shows high density lesion also around pleomorphic calcifications. Can you see that Q&A?
Yeah, the second one, it's not, is high density is actually, when the patient had come for a follow-up, it was not a mass. The area which is actually more of an asymmetry with calcification. So no definite mass could be made out on tomosynthesis sequences. So definitely the calcifications were really occupying a large area. They were almost segmental in distribution. So but there was no discrete mass. It was more of a calcification, group of calcifications in that area in segmental distribution.
Okay, thank you, Dr. Janagi and Dr. Venu sir. Any your comments, please?
Nothing. All the 3 residents, they presented very well, and all the cases were very good and typical cases and very informative and very practically very useful cases now. Only one thing, in the last session also I told the same thing, that is as far as the breast is concerned, the primary modalities are mammogram and ultrasound. Everybody knows more. So after that, immediately you should not jump. If something is seen, immediately one should not jump into MRI now. You should not ask for get MRI and then come back. Or you should not take the patient for MRI now. As Dr. Janaki rightly pointed out, say the thing is that if something is seen in ultrasound or in mammo, either you go for, if suppose it is not definite, it is not typical, or you are suspecting malignancy, then you go for either ultrasound guided FNSUR biopsy or stereotactic FNSUR biopsy, as the case may be. After that, after getting the diagnosis, then only the role of MRI in the, that is actually is for planning. So whether to go for breast conservation or for mastectomy, like that. So otherwise, there is no point in doing MRI for diagnosis, because actually you are seeing the lesion in ultrasound. See, once you see, suppose there are no lesions there, ultrasound is negative, mammogram is negative, but still one axillary node is there. So your clinician is suspecting some hidden primary in the breast. In that case, actually we can go for MRI. Otherwise, whatever we see, we have to limit the number of investigations as far as possible. So that is the main thing now. It's not like whatever investigations that we have, what our institution has having, okay, let the patient go through all the investigations. It should not be like that. So with the minimum investigations, we have to get the diagnosis. So for that, actually, there is no other way of going for biopsy. So that is the most important one. So everybody should master in doing procedures. So that's the only thing that I can tell you. Okay, thank you very much. Thank you, Dr. Janaki, for the nice selection of cases, and also making the residents present in a good way. Thank you very much. Thank you.
Thanks.